funding for public health throughout this crisis. The tens of billions of dollars we've provided through 6 COVID bills so far are supporting invaluable public health work at every level so we can finally end this pandemic. It has helped update and modernize data systems needed to track infections, variants, tests, vaccines, and inequities among demographic groups. It has helped fight misinformation and promote simple protective measures that have saved countless lives, like wearing masks and social distancing. It has helped expand our testing efforts, get vaccines into arms, and build partnerships with trusted voices in hard-to-reach communities. And I was pleased to hear the Biden administration announce last week it was investing over $7 billion from the American Rescue Plan through CDC to create tens of thousands of jobs in public health at the state and local level to fight COVID-19 and to help transition some of those workers to permanent careers as public health professionals. With new cases and deaths both down over 80% from their winter peaks, nearly 3 in 5 Americans vaccinated with their first dose, and over a third of Americans fully vaccinated, we can see the light at the end of the tunnel. But even as we get closer to ending this crisis, we know we are not there yet, and we cannot afford to come up short. That's why after years of underinvestment in CDC and attempted cuts to CDC by President Trump, this budget request is such a breath of fresh air. President Biden's request of $8.7 billion would increase CDC's budget authority by nearly a quarter. I've been pushing for more public health funding for years now, and I'm excited to say this would be the largest budget authority increase for CDC in nearly 2 decades. These investments will help us finish strong when it comes to this pandemic, prepare for the next one, and make progress on other public health challenges. Investments in CDC, as well as requested increases for the Substance Abuse and Mental Health Services Administration, will help address the record number of drug overdose deaths and the spike in mental health issues we have seen as a result of this pandemic. COVID-19 has also put a painful spotlight on how racism, sexism, ableism, and bigotry hurt so many people in this country. CDC's recent announcement of a 2-year plan to invest more than $2 billion to work on COVID-19 related health disparities was an important step towards addressing this reality. And the administration's request to dramatically increase the social determinants of health program Congress established at CDC last year from $3 million to $153 million will help make sure our response to health inequities is truly comprehensive. Because there are so many challenges we need to tackle head on. For example, Black, American Indian, and Alaska Native women are 2 to 3 times more likely to die from pregnancy-related causes than white women. And our overall maternal mortality rate is the worst in the developed country. So I'm glad the administration budget request includes $200 million to reduce maternal mortality nationwide and address disparities, an increase of $140 million. It also invests in other public health threats that have gone too long with too little attention. It doubles funding for gun violence prevention research and establishes a new $100 million community-based violence intervention program between CDC and the Department of Justice, and it increases funding for CDC's climate and health program by $100 million. Of course, the challenges we face are bigger than any one budget. Before this pandemic hit, only half of Americans were served by a comprehensive public health system. Our public health workforce had lost 56,000 people, and state health officials estimated a quarter of their workforce was eligible to retire. So we have a lot of work ahead, not just to end this pandemic, but to build and maintain a public health system capable of addressing other pressing public health challenges and, of course, preparing for future ones. That's why earlier this year, I reintroduced the Public Health Infrastructure Saves Lives Act, which would finally end the dangerous cycle of crisis and complacency in public health funding by providing dedicated annual investments in public health. Director Walensky, Principal Deputy Director Schuchat, I look forward to hearing from both of you about how investments like this and like those put forward in the administration's budget request can help families in states across the country. And I look forward to working with my colleagues to make the investments we need a reality. Finally, Dr. Schuchat, I understand you are leaving CDC this summer after 30 years with the agency, and I know I speak for absolutely everyone on this committee when I say I'm grateful that we've had your expertise and leadership helping to see our nation through so many public health challenges. Thank you for your service from all of us. And with that, I will turn it over to Senator Blunt for his remarks.
Well, thank you, Chair Murray. This is your first hearing as the Labor, Health, and Human Services Chair. I certainly look forward to working with you in this role. We've had a lot of success working together in the past 6 years on this subcommittee, and I'm sure we can continue with that this year. I also want to share your welcome to the CDC Director and the Principal Deputy Director. Dr. Schuchat, thanks for your service to our country and your incredible time at CDC. As I mentioned to you earlier as we were visiting, I'm sure there's not a single person who knows as much about CDC as you do, and there may never be a person who knows as much as you do after a 33-year career there and that long list of things that we've worked together on in the last several years, but a list that goes beyond that. So Dr. Walensky, Dr. Schuchat, this is really an important opportunity for us to hear about the CDC's budget proposal and understand more about CDC's priorities for this year. I don't think there's been a year that CDC got more attention than it got in the last year, and so the profile of CDC, the understanding the importance of CDC is, I think, at a high point. I want to recognize the tireless efforts of the CDC staff working across the country during the pandemic. It's been a challenging year for all Americans, but particularly for those in public health. Dr. Walensky, I look forward to hearing your testimony today on the administration's fiscal year 2022 budget. Unfortunately, your comments will be limited somewhat by the fact that we're really waiting for more information about that budget. But from what we do know from the limited details released last month, there are really several areas of alignment where we can work together. For example, addressing the needs of the hard-hit public health infrastructure, responding to the opioid crisis, which has been exacerbated during the pandemic, along with other mental health and behavioral health challenges, continuing the ending the HIV epidemic initiative are important to both of us. These are critical areas that may need even more attention as we emerge from the pandemic and gain an understanding of the full impact of the health impact and the behavioral health impact that the pandemic has had. It also appears that global health security and preparedness programs will continue as a priority for this administration, as it has been for this subcommittee over the past 6 years. During that time, the subcommittee invested heavily in these programs, increasing funding across the Department of HHS by 46%. Unfortunately, the so-called skinny budget also includes what I believe are excessive areas of increases in areas that are extremely partisan. I hope we can set those issues aside and invest in areas of common ground that benefit all Americans. As this subcommittee thinks about the priorities for fiscal year 2022, I hope we can spend time learning from the lessons of the pandemic. In 2020, Congress passed 5 bipartisan COVID relief bills totaling more than $16 billion for CDC. During the infectious disease pandemic, that funding was critical for state and local public health preparedness and response. I think we'd all agree that our focus on local public health in the country is not what it was just a few decades ago, and we can do better. Certainly, those agencies and state governments generally have been critical in the vaccine distribution and planning. Now, the other point to make is that $16 billion is a lot of funding to absorb. To put it in perspective, that's about double your annual budget, or more than $50 million per day for the CDC's response efforts last year. Pretty hard to spend all of that as effectively as this committee would like, but I think we understood that when we were sending money to CDC to try to respond to a pandemic that was unlike anything we had dealt with before. We also really need to incorporate the lessons learned from the pandemic moving forward. It's important we highlight what went right, when communities stepped up, when neighbors helped neighbors, when innovators came forward to provide novel solutions to some of the problems that plagued the pandemic. Senator Durbin and I and 6 of our colleagues went out Monday to NIH, and we saw what happened there with testing and other things that clearly, I think, as we look down the road, those are going to be great advantages for us. In Missouri, we saw a lot of those unique things happen. For example, the pandemic brought out innovation with Washington University in St. Louis, Dr. Walensky, where you got one of your degrees, developing their own testing. When there was a nationwide shortage of testing, there was a test that was developed at the Washington University campus to be used on that campus. Other resilience came through, other resourcefulness came through. Throughout Missouri, independent and rural pharmacists would drive 200 miles, some of them, to be sure they had the vaccine that would be available at their location the very next day, literally going the extra mile. The University of Missouri developed a cutting-edge technology to track COVID variants through wastewater epidemiology. So I'm proud of Missourians, I'm proud of Americans across the country as we reached out to deal with this. We're clearly not out of the woods yet. We need to continue to understand and learn from the mistakes we made to figure out where we fell short or missed the mark. Also to understand, frankly, that there were lots of things we know now that we didn't know then. Looking back at decisions where you don't have the same information or anything like it that we did now is a challenge. We need to figure out what we learned from that, how we could have found out more earlier. I expect the budget to do just that. I want to work with Senator Murray and others on this committee to do that. But under your leadership, Dr. Walensky, I hope the agency will make the difficult decisions necessary to make great strides toward the enormous opportunity that I think public health has at this moment for the rest of this century. So thank you for being with us today. Chair, again, let me say I look forward to your leadership and the things that we can do together, and I really appreciate where we are now compared to where we were 6 years ago, and I think our partnership was an important part of that.
Thank you, Senator Blunt. And yes, I do look forward to working with you on this, as we always have, so I appreciate it. I want to welcome both of our witnesses again. Thank you for being here. Dr. Rochelle Walensky is the Director of the Centers for Disease Control and Prevention and the Administrator of the Agency for Toxic Substances and Disease Registry. Dr. Ann Schuchat is the Principal Deputy Director of CDC and has twice served as Acting Director of the agency. Welcome to you both. Dr. Walensky, we'll begin with you for your opening remarks.
Chairwoman Murray, Ranking Member Blunt, and everyone on the committee, I'm grateful for the committee's support of the CDC. I'm here today, as you noted, with Dr. Ann Schuchat, CDC's Principal Deputy Director. I have enormous gratitude for Dr. Schuchat's leadership and contributions over 3 decades, as well as during this very challenging period for our country, and for her rock-solid support of me in my transition into this role. Ann embodies selfless public service, the pinnacle of scientific and intellectual standards, and has given her heart to our agency and the public health community. I will be forever grateful that our paths crossed even for such a short period of time. The COVID-19 pandemic threw the United States and the world into a health, economic, and humanitarian crisis. As the crisis unfolded, it put a spotlight on the fragility of our public health infrastructure. It illuminated great disparities in health outcomes by race and ethnicity, reminding us that, thus far, we have failed to address the systemic racism that results in poor health for people of color in the United States. I am committed to working with you, the administration, and our public health partners to ensure that every lesson from this horrible crisis is used to build a better, stronger, healthier America. I also commit to using our public health expertise and experience in partnership with the global community to move the world into a safer, healthier future. CDC's fiscal year 2022 discretionary budget request of $8.7 billion is an increase of $1.6 billion over fiscal year 2021, the largest increase CDC has received in nearly 20 years. The increases focus on 4 critical areas: building public health infrastructure, reducing health disparities, using public health approaches to reduce violence, and defeating diseases and epidemics. These increases build on the investments made in the COVID-19 supplements and are an important first step in addressing deficits in the public health infrastructure. COVID-19 not only exposed the vulnerabilities within the United States public health infrastructure, but also how underlying chronic conditions and lack of access to health care put too many Americans at great risk. Across the globe, we see billions of people without access to vaccines and medical care, which means that SARS-CoV-2, its variants, and other infectious disease threats will continue to threaten us all. Experts had warned for years that a pandemic of this scale was coming, and we must expect additional diseases to emerge. We need to ask ourselves, are we ready? We must have a strong infrastructure that can identify and detect outbreaks at their source and can take quick action before diseases take hold. Over the last 12 years, the United States has faced 4 significant emerging infectious disease threats: the H1N1 influenza pandemic, Ebola, Zika, and COVID-19. We also confronted a drug overdose epidemic, with nearly 500,000 people dying from an opioid-related overdose between 1999 and 2019. This increase continued into 2020 and appeared to accelerate during the COVID-19 pandemic. These experiences show that public health emergencies are here to stay. Each of those threats demanded a rapid and unique response, but none resulted in a sustained public health improvement. Long-term investments in flexible infrastructure will save lives and avert economic losses caused by public health emergencies and chronic public health problems. The fiscal year 2022 request makes initial investments to continue public health data monetization, build the public health workforce, enhance global health security, and strengthen our immunization infrastructure. In addition, we are requesting funds to help states and communities be climate ready and prepare to confront new health risks, such as those associated with vector-borne diseases. The fiscal year 2022 budget request also makes specific investments in programs that work to improve health equity, such as maternal mortality review committees. With these new outlined resources in this request, CDC will also significantly expand efforts to address the social determinants of health. Proposed increases will address public health problems that have been exacerbated by this pandemic, such as opioids, injury and violence, HIV, and sexually transmitted diseases. We at CDC are grateful for your support and look forward to working together to build a sustainable and resilient public health system that can respond effectively to emerging threats and meet the public health needs of every American. We will work tirelessly to ensure the health of this nation and the world. Thank you, Dr. Schuchat, and I look forward to your questions.
Thank you very much. We will now begin a round of 5-minute questions of our witnesses, and I do ask my colleagues to keep track of the clock, and if you can, stay within those 5 minutes. Dr. Walensky, COVID has really exposed the importance of having a robust and well-funded public health system before a crisis strikes, which is why I said it's so important that we make and sustain investments in public health infrastructure and workforce a priority, including in CDC. Over the last year, Congress provided more than $8 billion to support public health data modernization and expand the public health workforce through 6 COVID supplemental bills. What more needs to be done to sustain our public health infrastructure and our workforce so we don't lose these gains when the funding runs out?
Thank you so much, Senator, for that question. You've highlighted that we've had challenges with our public health workforce indeed. We have 56,000, we're down 56,000 jobs just in the last decade. We need to train and upskill that workforce in addition to bolster that workforce over the years ahead. We need to keep them trained because the science continues to evolve. We need training in bioinformatics, in genomic epidemiology, and all of that needs to live in our state and localities so that they are well informed and trained over time, not just in creating the workforce, but in keeping them skilled. We need to do data monetization, as you noted, an initial investment in data monetization. When I spoke early on in my tenure to state and local health officials, I was hearing about faxes of test results by COVID and then manual data entry of those results, and that those results were not received with racial and ethnic data in them. So we had no way of tracking how we were doing in our racial and ethnic diversity across this pandemic and the distribution across this pandemic. And then we need to build our public health labs. We didn't have the capacity to do genomic sequencing in all of these labs. We've had to scale that up. And there's many more in the infrastructure, in the machinery, in the technology that we need to put and deploy, not just at CDC, so we're ready at CDC for this, but also in our public health and localities.
So I'm curious, if we had had all that in place before this pandemic, how would have things been different?
I think they would have been extraordinarily different. We would have had contact tracers on the ground ready to go. We would have been able to identify cases quickly. We would have been able to see single outbreaks and clusters that we might have been able to pin down, contact trace, and not have expand. I think we wouldn't have seen the racial discrepancy in what happened with this pandemic.
Because we would have known prior and made more of a focus.
Exactly. We would have been able to find it. I think the testing, the inability of our public health systems to be able to conduct these tests in massive scale up didn't allow us to find the disease where it was. Certainly we hadn't done genomic sequencing until January. We didn't know anything about the variants that were circulating here. There are innumerable ways that this could have gone better if we had had a more robust public health infrastructure across all of those domains.
Thank you. That's a lot to think about. We should all remember. We have now seen a lot of encouraging progress against COVID over the last several months, and as more people get vaccinated and case counts and hospitalization deaths are falling, Dr. Walensky, speak to us about where we are in this fight, how the funds Congress has provided have helped, and what we need to focus on next to bring this crisis to an end.
Today, I'm cautiously optimistic. We have, in the last several weeks, seen a stark downward trend in cases. The last 2 days, we've had case rates that have been less than 20,000 per day. Our case rates now are around 30,000 per day on average for the last 7 days. Death rates we haven't seen at around 500 a day, still too high, but the lowest we've seen since this pandemic began. We have over 86% of Americans over the age of 65 who've received their first dose of vaccine. And just today, we have now 60% of Americans over the age of 18 having received their first dose of vaccine. I think that we've had extraordinary progress, and we've needed the resources to get here.
So what do we need to focus on next?
Certainly a sustainable public health infrastructure that is not necessarily just tied to one disease, to one outbreak, to one disaster. We need longitudinal money so that we are able to have sustainable infrastructure that is up to date with the times. We need to focus on our racial and ethnic minority groups. They were previously under-vaccinated. We've made a huge amount of strides just in the last 2 weeks in getting those groups vaccinated. But we need to get into the communities. We need to have a public health infrastructure that looks like the communities that they serve and that serves those communities in that outreach.
Should we be worried about the variants?
I think we would be remiss to say that we are out of the woods. This pandemic, this virus has sent us too many curveballs to say that we too early to declare victory. Certainly with virus circulating in other parts of the world, that is in high degree that gives the opportunity for more variants to emerge. So I still, it's among the things that keeps me up at night. But right now, the variants that we see here, and we're doing a lot of sequencing now, demonstrates that our current vaccines are working.
Okay, thank you very much. Senator Blunt.
Thank you, Chair. Let's talk about the guidance that came out last week on masks and for people who've been fully vaccinated. There seems to be some concern about how that would be applied. I listened this morning to the CEO at Target, who was on CNBC, said that they had followed all the CDC guidance up till now, which meant until last week people in their stores had a mask on. This week people in their stores don't have a mask on unless they want to have a mask on. In the Capitol, the attending physician, who has been the person we look to, put out guidance last week that said on Capitol grounds you wouldn't need to wear a mask if you were vaccinated, but the speaker decided that she was going to keep the mask mandate in place for the House until everyone was vaccinated. What are you seeing there, and what kind of further direction have you been able to give to CDC? I know especially the president had his mask on part of the time, largely based, it seemed to me, on what other people around him were comfortable with, but give us some more thoughts on that.
Thank you, Senator, for that question. I think the first thing that we should do is celebrate where we are in this pandemic, that we can even be having this conversation, that cases are now down to 19,000 a day reported this morning. As those cases are coming down, people are longing to understand what this means next. How do we open up again? How do we take our masks off? With those cases coming down, and now the fact that every American who wants a vaccine has access to one. If you haven't texted, go get Vax 438-829. You can find vaccine wherever you are in the country. Five pharmacies will show up so you can get vaccine. So we now have cases coming down and access to vaccines for everyone who wants one. Just in the last 2 weeks, we had scientific data emerge in 3 important areas. One, that the vaccines are working in the public the way they worked in the clinical trials. That doesn't always happen, but it happened here, and we had one of the largest studies published on Friday in the MMWR. 2, that the vaccines are working against the variants we have here circulating in the United States. There have been data, neutralizing data, that demonstrates against B117, against B1351, our vaccines are working. And 3, something that wasn't studied in the clinical trials, is if you were to get infection and vaccinated, could you give it to somebody else? Were you silently able to spread it? Those data were not covered in the clinical trials, but now data have emerged again that have demonstrated that even if you were to get infected during post-vaccination, that you can't give it to anyone else. So that scientific data was enough for us to move forward. People had said we'd move too slow. People have said we've moved too fast. We moved at the speed that the science gave us.
Well, I think that's right. I do think on the last topic, if we not evaluating whether we could have made that decision quicker, but I do think that decision that you don't have to wear a mask once you've been fully vaccinated will encourage people to get vaccinated. I think the fact that that's out there is good. I hope we got it out there as quick as you were comfortable having it out there. On your comments about racial health disparities, which of course I'm not for racial health disparities and more than happy to look at that. What about the other obvious health disparities, like low income health disparities regardless of race, or rural health disparities? Are we just going to focus on racial health disparities and leave those others behind, or why were those the disparities you mentioned in your report, in your comments?
We've seen a lot of data on racial health disparities in this pandemic, but Senator, you're absolutely right. 20% of Americans live in rural areas. As we talk about social determinants of health, this is not just racial, on racial lines. This is urban and rural. We just yesterday had an MMWR come out that demonstrated that rural Americans were getting vaccinated around 39%, while non-rural counties were at 46%. So our intent and our values are going to be to have public health reach all areas, all Americans.
I'm glad to hear that. My last question here before I run out of time would be on drug overdose deaths. You know, we saw this committee worked really hard on this topic for about 4 straight years, and we felt we were making some real progress, and I think we were. They were going down every year, but in 2020, the highest number to date of drug overdose deaths. Just comment briefly on that before my time's up here.
It's tragic. Before being here, I was an infectious disease doc on the wards at Mass General, and while we're talking about deaths, the people on the wards are also talking about chronic infections, endocarditis, epidural abscesses, leaving young people paralyzed. We were making some progress, and this pandemic hindered that progress, and we again need to address this issue.
Thank you.
Thank you. Senator Durbin.
Thank you, Madam Chairman. And Dr. Schuchat, let me join the chorus. Thank you for 33 years of remarkable service. I have a question for you in a minute, but I want to start with a little different approach. And let me say that I think this pandemic has not broken us, but it has taught us where our system is broken. And there are many areas we need to look at seriously. If you took a look at the public health scorecard and try to find an objective measure, the one that I return to frequently is the fact that the United States has less than 5% of the world's population, yet 20% of the COVID-19 infections and deaths. And that tells us we can improve dramatically. Where did we shine in this effort? Certainly vaccines. The quick response, as we learned again this week in a visit to NIH, was because we were prepared and we had the science ready, and we had good fortune in identifying the culprit and in devising an effective strategy to go after it with vaccines. I would also add that the Warp Speed program appears to have dedicated and invested funds in a dramatic way at a time when it was very important. And I think that accelerated the availability of the vaccines, and I give the Biden administration credit for administering them and distributing. So those are the positive sides. But one of the messages that I learned out at NIH was, now let's get honest about this. We not only have to bring this pandemic to an end, we have to prepare for the next pandemic, which may be 5 years away or 15 years away. We don't know. But history tells us there will be another one. And the question is, will we be ready for it? The CDC is going to play a critical role in this. And the first question I have to ask is to Dr. Schuchat. After 33 years of observing this agency and its role in the American scene when it comes to public health, there's a fear that it has been politicized in the last 4 years, or maybe even before, and that now public health issues are so political. When the division on whether to get a vaccine or a vaccination or not seems to break out on party lines and political lines, we've reached a new stage. What is your thinking, and having observed and worked with the CDC all these years, about this politicization, if that's the word, of public health?
Thank you so much for your comments and your question. The viruses don't vote, and the pandemic has really told us that everyone is vulnerable, everyone in America, everyone around the world. And CDC is a science-based agency, and we lead from science. We're data-driven, and we work together with state and local partners who reflect the values of their communities. So I think that focusing on the science and the service mission of the agency is what we need to do.
Have you noticed any recent change in terms of the political image of CDC, which tries to be apolitical?
You know, this pandemic has been so difficult for, for the nation, I think for all of us in public health and certainly for our colleagues around the world. The messaging has really been difficult, very conflicting messages that left Americans confused. And so I think we're committed to clear, honest communication of what we know and what we don't know and what we recommend people do. So I do think the messaging environment this past pandemic has been really tough.
I would agree with that. Dr. Walensky, I'm worried about gun violence. I believe it is a public health issue because I represent the state of Illinois and the city of Chicago. And we have the equivalent of a mass shooting every weekend in Chicago. It is a disaster in terms of its impact on the lives of many people and the life of the city. You have a proposal to make a $100 million investment through the CDC in community-based violence intervention, working with neighborhood organizations and hospitals to deliver services. I commend to you a program which we've started in Chicago called the HEAL Initiative. I'll send you some information on it. But I'd like for you to say a few words about what you anticipate that $100 million is going to be used for.
Thank you, Senator. Our intent here is to look for areas in high violence cities where we can accumulate data, we can get accurate information, where we have actionable interventions to prevent all areas of violence, community violence, domestic violence, suicide, to increase public health using those resources in areas that have been highly impacted. We want actionable interventions for prevention.
Thank you. Madam Chair, I would just say in closing, you're in a unique position being on the Authorizing and Appropriating Committee. But one element I hope we don't overlook, and I know you feel sensitive to this as I do, is the need in schools to have access to counselors, mental health counselors, and maybe traditional school nurses, so that any public health effort, which should focus first on our children, has the wherewithal to do that effectively. I find that we have allowed that to lapse in many areas of my state.
Thank you, Senator Durbin. Senator Hyde-Smith.
Thank you, Chairwoman Murray and Ranking Member Blunt, for having this hearing, and I certainly appreciate the speakers that are here today. And Dr. Walensky, I appreciate being able to visit with you last week to discuss your work as director of the CDC and the prevention. I thought we had a very good conversation. Certainly admire the work that you've done. And Dr. Shukat, I certainly admire the work that you have done over the past many years. I'll be brief with my questions, but one thing that I'm really concerned about is rural health care. I had the opportunity this past Saturday morning to visit with David Reddy. He's a pharmacist in a town in Mississippi, Monticello, Mississippi, that has less than 1,500 people, and the concerns that he has about them being able to get their medicines, the reimbursements they get, because they're such a small, they don't buy in bulk. So those are things that I'm sure that we will be having other conversations about. But the COVID-19 pandemic was highlighted numerous aspects, obviously, of our healthcare system that needs improvements. One of them that we all recognize is the disparities America's living in rural health areas, facing our rural health areas. But addressing health infrastructure in rural areas is a serious concern, and as I said, one of my top priorities. And while the CDC has undertaken efforts to address that, there's no entity within the CDC tasked specifically with this work, and that's concerning to me. I believe establishing a new Office of Rural Health within the Center of Disease Control would be an important way to support rural communities through the end of this pandemic and to prepare for any other future public health crisis that we could be faced with. And, I just envision this office to be empowered to look across CDC programs to ensure the work of the agency is properly addressing the health needs of the 57 million Americans who live in rural communities. Director Walensky, how strongly do you support establishing an official Office of Rural Health within the CDC, and how can we work together to get this done if you see that the way that I see this?
Thank you, Senator. As you noted, we have 20% of Americans, 57 million Americans living in rural areas. Part of the deep need for investment in a public health infrastructure is to develop a workforce that looks like the community, that is from these communities, that knows how to access and reach these communities, which is exactly one of the challenges that has occurred during this pandemic, and one of the reasons we had differential distribution of vaccines between rural and non-rural communities. We also know that there are other ways outside of COVID that we learned from COVID, such as telehealth. We had a previous MMWR that demonstrated, ironically, that telehealth was not reaching rural communities. And that is, in fact, one of the areas that we should be using telehealth, in fact. So why was it not reaching the rural communities? CDC is investigating this just by virtue of the fact that they've had several MMWRs in the last 2 weeks examining these issues. So as part of the public health infrastructure, as the disease agnostic infrastructure that works on labs, that works on workforce, that works on data, we are invested in urban communities as well as rural communities.
And I think a lot of that is broadband issues as well that we have to get addressed. But I understand the CDC has a highly categorical manner for providing funding to state health departments, with most funding tightly tied to specific diseases or specific purposes. And I'm concerned that restricting CDC money to specify activities prevents states from being able to address issues that vary from state to state, because all of them are different, and it makes it difficult to respond efficiently to emergent challenges like COVID-19. And I've always been big on flexibility, because the states really know where their needs are, and I believe greater flexibility on funding might allow states to better target resources. So I just wanted to mention that to you, of the flexibility there, that we sure saw that our hands were tied in some cases during COVID. So I just wanted to address that with you.
I would just echo your thoughts and say, yes, one of the things that has been challenging for us at CDC is line items that have to go to X or Y, when in fact what we need is the infrastructure, the disease agnostic infrastructure, so that when we see this community needs this, but they may both need to establish a lab, but one needs broadband and the other needs a genomic sequencer, that it's flexible enough to be able to make sure that each of the communities can scale up for what they need. Absolutely.
Thank you. That's very encouraging. Thank you.
Senator Reed.
Well, thank you, Madam Chairman, and thank you, Director, for your extraordinary work. I've been working and trying to bolster the Section 317 immunization program for many years, and as we recognize this year, because of the pandemic, there's been significant increases in vaccination funding, going out and building an infrastructure, but I don't want to take our eyes off the long-term need for Section 317 programs to sustain improvements that have been made in terms of routine immunization, which must be given. And so will the CDC request an increase in funding for the 317 program this year, Madam Director?
I'm going to let Dr. Anshook take that question.
I want to thank you for your longtime support for the immunization needs of the nation and the incredible progress we've been able to make, particularly among children. COVID, the pandemic, has really highlighted that we are not where we needed to be with adults, and that was part of the slow start that we had in terms of getting, having the scale up of vaccination. So there is a lot more work to do to catch up for the vaccines that weren't given during the pandemic in children, and to strengthen our infrastructure for adults going forward. And so that work is part of the priorities for the agency.
Thank you very much. Dr. Walensky, this is not the first time I think this topic's been breached, but suicide epidemic has been startling across the country, related to pandemic and perhaps related to other factors. And CDC has produced some startling statistics recently about suicide. I know that CDC has launched some new suicide prevention efforts over the last couple of years, and let me encourage you to continue to do that. But I understand only a handful of grants applications were able to be funded, and one of those that were not funded was from my state, but we were not alone. And what are you intending to do with respect to the overall suicide epidemic and also the more robust funding for prevention?
Thank you, Senator. This is such a challenging area. We had scale up of mental health challenges before the pandemic, right? So these were issues that we really needed to tackle before the pandemic, and we saw during the pandemic that these have only gotten worse. Among our youth, among our middle-aged, we've seen challenges even since the pandemic began. So part of our resources that we're requesting is to scale up these efforts. Again, we need surveillance data. We need to understand how much this is a challenge, how many people are presenting to the emergency room. We need toolkits to deliver to states, to physicians' organizations, so that they are empowered as to how to prevent it. And then we need actionable implementation that we can do for prevention in the areas of mental health.
Thank you. One final topic is lead exposure, which I have been working on through my responsibilities on the Bank Committee and also the Appropriations Subcommittee on Housing and Urban Development. Over the last year, rates of screening for lead poisoning have decreased, obviously, as movement and these types of activities have been curtailed. And then I think the statistics will be probably very dubious coming out of the last year because of all these other factors. But it is a continuing problem. And right now, CDC's lead poisoning prevention program is at a high mark of $39 million. But we know more funding is needed. And we also know that this is an issue that disproportionately impacts low-income communities because of the housing circumstances generally. And I would hope that the President's CDC budget will prioritize his work, keep increasing funding, and focus. I would note he's going after the lead pipes, which I applaud. But in many respects, particularly in older communities like mine, the issue is the lead pipes, it's housing and lead paint, and it's a whole series of issues.
Thank you. I think this raises a very similar point as was previously raised by Senator Hyde-Smith, that each community needs individual things to improve the health of their community, which is why the public health infrastructure flexibility, the funding to be able to get the resources that you need in individual communities. One will be, we need resources for broadband, but one will be, we need resources for lead. So, and as you note, we again had an MMWR that demonstrated exactly what you said. Screening for lead this past year has gone down. We know we've missed lead toxicity that we really need to make up for.
Thank you very much. Thank you, Madam Chairman.
Thank you. Senator Moran. Senator Kennedy.
Thank you, Madam Chair. Madam Director, thank you for being here today. I know how busy you are. I've been in my office listening to some of the testimony of both of you, and I'm a little uncertain about some of the answers, which is probably a shortcoming on my part. Madam Director, could you in 1 minute summarize for me what the recommendations are today from your agency about wearing masks?
Absolutely. First of all, can I just say thank you for your YouTube video for promoting vaccines, which I just adored.
Did you like my singing?
Yeah, I did. Yeah. Thank you very much for doing that.
You're under oath now,
Yes, I did. Even so, I did.
Thank you for that.
Last Thursday, we released guidance that demonstrated for an individual who is fully vaccinated and not immunocompromised, that they are able to safely unmask, with the exceptions, certain exceptions, of course, in travel corridors, healthcare settings, that if you are an individual, you can safely unmask if you're fully vaccinated.
Inside and outside?
Inside and outside.
Okay. What role do the state regulations play with respect to that?
We are working now to update all areas of guidance, but here's what is really, I think, important to understand. We are not a homogeneous United States. We have counties that have less than 20% vaccination.
Yes, ma'am, but I don't want to get too off the question here. If I walk over to the House of Representatives, do I have to wear a mask?
Those are locally driven policies, but we felt that it was important for the science for us to convey the science of what is safe for individuals.
Well, I'm trying to understand the CDC recommendations, and I appreciate it. Based on the CDC recommendations, if I walk over to the House, are you recommending I wear a mask?
If you are by yourself walking over to the House and you're fully vaccinated?
No, ma'am, once I'm over there. I'm vaccinated. Once I'm over there and I'm talking to some of my colleagues.
We have really encouraged that the policies of mask wearing be locally driven, and the reason for that is because every community, every county has different rates of disease and different rates of vaccination, and that's really
what's different about the House? Do you know?
I don't know the rate of vaccination around the Capitol nor the rate of disease around the Capitol off the top of my head.
Okay. What about airplanes?
What is the policy on airplanes? The policy on airplanes is to wear a mask.
Okay. And why is it different on an airplane as opposed to a restaurant?
So the CDC provides guidance for what is safe to do. The federal policy is obviously an interagency policy that we need to look at across different agencies. What I will say, though, is that there's very little choice when you board an airplane as to who's going to be sitting next to you, who's around you. And also, airplanes may be a place where we have more variance because of the travel from international places.
Okay. Last question. What, in your opinion, was the origin of the virus?
This has been studied by the WHO.
No, ma'am, I'm asking your opinion.
I don't believe I've seen enough data, individual data, for me to be able to comment on that.
What are the possibilities?
Certainly the possibilities of that most coronaviruses that we know of are of origin from, that have infected the population, SARS-CoV-1, MERS, generally come from an animal origin.
Are there any other possibilities?
Certainly a lab-based origin is one possibility.
Okay. Is the United States funding gain-of-function research?
Not to my knowledge.
Okay. Can you get an answer to that for me and let us know what the committee know?
Dr. Fauci would be the one who knows best, and he testified last week.
Dr. Fauci seems confused. I'm asking, with all due respect, I'm asking you to get us that information. Where throughout the world, including but not limited to the United States of America, are we doing research on these viruses to make them contagious in order to study them? That's what I mean by gain of function.
I understand. We certainly can have our staff look into this. I don't know that we have the access of labs across the world, just the ones that are funded here in the United States.
But you're the head of CDC. I bet if I bet that you get your phone calls returned.
Okay.
Would you get us that information?
I'd be happy to give you the information to the best of my ability.
Okay. And I'm going to do a complete album of my singing. I'll send you a courtesy.
Will you sign up, please?
Sure. Thank you. Thank you both for being here. Thank you, Madam Chair.
Senator Baldwin.
Thank you, Madam Chair. I want to pursue a similar line of questioning that we just heard from Senator Kennedy with regard to masking guidance. And when I reflect from the period of time when the pandemic was first identified, the Department of Labor and the agency charged with occupational safety and health did not issue any sort of emergency temporary standard with regard to workplaces relating to this pandemic. And frankly, while there's been much work done on that in this new administration, we don't have one yet. And so I'm just delighted by the progress we're seeing. Generally, I see that light at the end of the tunnel getting brighter and brighter and brighter. And certainly the CDC's updated mask guidance for those who are vaccinated is a reflection of that progress. But I am concerned about the impact of this guidance on workers, and particularly those who work in crowded conditions, such as meatpacking facilities, where we have seen horrendous outbreaks in the past year. So, Dr. Walensky, I'm wondering when we can expect perhaps more detailed guidance for workplaces such as meatpacking plants and other crowded facilities where there's going to be a mix of vaccinated and unvaccinated workers, and how that's going to interact with the very recent CDC guidance on mask use for those who are vaccinated. What should workplaces be doing right now?
Thank you so much, Senator Baldwin. The meatpacking situation was really, really difficult. So many people affected and lives lost, and a real challenge for the nation to react to that. Updating guidance for workplaces, including the higher risk ones, is a high priority for us that we're actively working on. As you know, the initial individual guidance came out last week, but updating guidance for particular settings is critical. Our National Institute of Occupational Safety and Health is working closely with OSHA around getting the best science to the Department of Labor, who has regulatory authority, but we are at CDC updating our guidance for the particular settings in light of the newer science.
I appreciate that. I want to ask a question of you, Dr. Schuckett, about the importance of communication in public health. Early in the pandemic, again, we had to get out a lot of information on what COVID-19 is, how it's spread, what precautions people can take. And likewise, now we're in the vaccination phase and we have to communicate about its safety, efficacy, availability, et cetera. Last year, I wrote the CDC requesting that they provide information on the spread of COVID-19 in Hmong language. The CDC later updated their material, which was extremely helpful for Wisconsin's vibrant Hmong community. But we also need to make sure that we are doing exactly the same to make information on the COVID-19 vaccine accessible and available for all communities. So, Dr. Schuckett, how is the CDC using what it learned from sharing information about the spread of COVID-19 to communicate the importance of getting vaccinated to those who have limited English proficiency? And will the CDC be making information on the COVID-19 vaccine and how to get vaccinated available in more languages?
Yeah, thank you so much for that set of questions. I think that communication has never been more important nor more difficult than the past year, and reaching people with limited English proficiency has been really important. We have a toolkit available in 34 languages, and our vaccine information, including our vSafe, the little app that helps people follow side effects after getting vaccinated, is available in multiple languages. But it's not just what we say, it's how we say it and who says it. And so one of our strategies is working through trusted messengers and partners of the community, from the community, who work with groups day in and day out. And so part of our strategy is funding of jurisdictions for them to have community-based groups really get that message out in ways that are accessible. These are really important issues, as we know. Back to the meatpacking outbreaks, we had people speaking multiple languages in very close quarters at risk for spread, but also not necessarily knowing who they could trust in what they should do. So we clearly want to get the vaccine information to them. Another thing I would mention is the partnership that CDC and the administration has had with HRSA around the federally qualified health programs, because they have, the federally qualified health centers have a real concentration of patients served with limited English proficiency, and both through mobile clinics for vaccination and through community vaccination sites, they've been able to reach those groups.
And Senator, if I might add just real briefly, one of the things that would be really helpful for us is working with those industries to encourage employers to get their employees vaccinated, that time off, paid time off, to ensure that they, when they return to work, they are vaccinated.
Thank you, Senator. Senator Braun.
Thank you, Madam Chair. Dr. Walensky, I'm glad that the recent ruling was made that if you're vaccinated, you don't need to wear a mask. I think it was getting very confusing for not only getting more people vaccinated, because they were saying, well, why should I get vaccinated if I still have to wear a mask? So thank you for that. But I do have a question. I know that on March 29th, the president was criticizing some governors about removing mask mandates, and of course that now has changed, and I think the reason is what I've just said. But what about, since the science now and the guidance is clear, what about local mayors and governors that aren't following the science, when that has kind of been ballyhooed as the thing to do? I believed in that from the get-go as well. Especially when the tools were very uncertain, the distancing and all that stuff made sense. I thought you were silly not to abide by it. What about now for the places that are, I think there's a liberation feeling out there, and thank goodness for the warp speed and getting the vaccines in the arms. Is this unnecessary for governors and mayors across the country to still keep a mask mandate in place?
Thank you for that question, Senator. We released guidance on Thursday that said for individuals, if you are vaccinated, fully vaccinated, you can take off your mask with several exceptions. One of the things I think that's really key in this is to recognize that we're not a homogeneous country, that there are some areas, that some counties that still have less than 20% of people vaccinated. There are some counties that still have greater than 100 per 100,000 cases in a 7-day period of time. And so I actually think, as I look at the map, a very heterogeneous map of how we're doing with cases, how we're doing with vaccinations. The decisions about whether to take off a mask mandate have to be made at the local level, have to be made at the community level. There are still some communities who are suffering. We know African Americans lost 2.9 years of life compared to white Americans losing 0.8 years of life. We need to make sure that, and they are probably the communities that got access to vaccines last. We're working on that. We've had extraordinary improvements in our access to, in our racial and ethnic minorities having access to vaccines. But I do think that these need to be made at the local and community level for exactly that reason.
Do you think it'll be confusing, though, even for those places that have lagged in getting their citizens vaccinated, to see that there's not that incentive in place, even in the places that have been slower to do it, that would be an encouragement if they see people without a mask and they say, well, they're vaccinated, I want to get one?
I think it would be really amazing if our new guidance got more people vaccinated and was an incentive for more people to get vaccinated. But I don't make CDC guidance. My whole agency does not make CDC guidance based on what it will help people do. We have to do it based on the disease that's out there, the access to vaccines, and based on the science that has emerged. I really am hopeful that that will help and to incentivize people to get vaccinated, but that wasn't the reason for our guidance.
Okay, another subject. Since we're kind of at least ebbing into a situation that looks like here in the U.S., other countries, some places it's still running rampant like India, when do we turn the focus? And I think we've been lucky that vaccinations have come this quickly. But therapeutics would seem to be that final defense for anyone that did not have a vaccination available. And now for the few cases that could still slip through the cracks to where it's impacted with so much data, such a small portion of the population, disproportionately and horrifically, elderly, predisposed with other conditions. When do we start turning our attention to helping them once they get it? Because we're going to still have cases, depending on variants, how strong they are, to where the emphasis goes to therapeutics and not vaccinations, especially for places where the vaccine is generally working, but you still want to have tools to help those that get it.
Absolutely, and I know. First of all, I think we're working now. We have said if anyone is not safe, then no one is safe. We really do need to make sure that we have resources to other places. If variants emerge, they will come to our shores. So we have to be able to do that. I also know that NIH has invested in making sure that we have therapeutics. One of the first things that we had when I was rounding on the wards last May was remdesivir, and that was the first sign of an antiviral. We don't have anything really that we can give quickly over the by prescription to outpatients. Right now, we're relying on monoclonal antibodies. They're hard, they're clumsy, they take a lot of resources, they're expensive, and so I do believe that we need, in this next phase, after we get the majority of Americans vaccinated, we do need to turn to antivirals that are able to be easily administered in an outpatient setting.
And final comment, I think that's going to be important because we don't know how much variance will become an issue. And at some point, when we've generally tamped it down, I think it's incumbent on us to put focus on how to help those that end up getting it, especially that are so predisposed with bad outcomes. Thank you.
Thank you.
Thank you. Senator Manchin.
Okay. Thank you, Madam Chairman. Appreciate it very much. And I want to thank all of you for being here. Dr. Shukut, first of all, thank you for your service, many, many years of service. And I appreciate very much what you have done. And my first question will go to you because you probably have the historical knowledge of how we got to where we are. Over the last decade, the United States has lost over 50,000 public health jobs. And during that time, we have faced the H1N1 flu outbreak, Ebola, Zika, and now COVID. Within the last 5 years alone, West Virginia has lost nearly 30% of our public health workforce. One thing we know from this pandemic is that we were not prepared. While we have been able to hire temporary public health workers in the last years, these positions, they're not permanent and are at risk of disappearing after the public health emergency is over. So can you speak to how we became so vulnerable and fell behind the curve in our ability to respond to this pandemic? And how can we keep it from not happening again? I know you all touched on it, but I just can't believe we were this unprepared.
Yeah, I think the state of our preparedness was a real tragedy, and part of that relates to the public health infrastructure. Over and over, we invest in response to a crisis, but in ways that haven't provided sustainable capacity at that front line where the problems happen.
Was these decisions made higher up within whoever the administration may have been, whether it's Republican or Democrat? Was it made at that level, or was it made at the head of the CDC?
The biggest funding increases we've gotten have been emergency funds from Congress that, happily supported response for H1N1 and Ebola and Zika and COVID. But the dollars that were there day in and day out to provide reliable jobs for that local public health workforce were not there. And whether it was state budgets or federal budgets, you cited the statistics of the job loss. Beyond that, the jobs aren't the same anymore. We talked about the data. Our data systems have really not kept up with the times. We have very fragmented data systems that have not been modernized.
My time is limited. I want to ask Dr. Walensky's question, but on this, Dr. Shukut, what type of a time basis would you say that we should be looking at for funding? I mean, to have confidence in the funding, permanent funding over a 5-year, 10-year period, so it's consistent, you know what you can do and be prepared?
You know, I think the approach that was taken for NIH to strengthen their capacity for vital biomedical research is what needs to happen for the vital public health infrastructure in the country, where it's not a feast and famine, but that local, state, and federals can plan.
Well, now would be the time to do it. If we're ever going to do it, we should do it now, since it's all very, very fresh in what we've been able to endure. Dr. Walensky, as you're aware, we're facing an epidemic with pandemic. West Virginia is ground zero for the drug epidemic, with the highest rate of drug overdose deaths in the country. To make matters worse, 2020 was the worst year yet, with over 90,000 deaths. We saw at least 47% increase in the state of West Virginia with overdose deaths. So what resources is CDC providing to states to combat the epidemic?
Thank you, Senator, for that question.
And also, a second part of that would be working on helping, what CDCs are working on helping increasing testing for viral hepatitis and HIV. We've had a tremendous, horrendous situation with that.
I can tell you, just before coming here, I spoke to one of my infectious disease colleagues in West Virginia, and she was telling me that they have opened neonatal detox units. I understand.
Unbelievable.
It's unbelievable. It's unbelievable. And so we know that we need to tackle this. We need to encounter this. We need accurate data. We need interventions that can, and we need resources to be able to invest in opioid naloxone programs that are reaching the community health workers that can do the outreach to talk to people and intervene at the local level where these are happening. We need toolkits. We need information and mental health support services to intervene.
My time's running out. I want to ask you one other thing. We produce very little of the things that we basically need for medicine. Penicillin, do you think penicillin should be produced in America? Do you think doxycycline should be produced, an antibiotic in America? And if so, what should we do in order to do that, or stockpile strategically for our own protection?
I think we need to have a public health infrastructure and a pipeline that allows us to respond to pandemics and to epidemics and to infectious threats.
Do we have any manufacturers that are producing these in America?
There are limited manufacturers producing penicillin, that I can tell you, because in fact we've had penicillin shortages. Penicillin has gotten extraordinarily expensive, and in fact some colleagues of mine have once said it should be cheaper than the tubing it runs through, and in fact it's not.
Should the CDC basically, I mean, your recommendation would be for production, we should be producing these in America. We need to have something from a professional like yourself to get back to producing things in America, not depending on foreign supply chains.
So one of the things I can just mention for penicillin specifically is it's particularly hard, given the allergies related to penicillin. It's actually particularly hard to do. There are limited plants that make penicillin, but your point is well taken.
Thank you. Thank you, Madam Chairman.
Thank you. Senator Moran.
Chairman, thank you. Thank you, and Senator Blunt, for this hearing, and welcome to our two doctors. Thank you for your service. I have 4 questions I'm going to try to accomplish in 5 minutes. Let me first highlight something that's occurring in my home state. Kansas will soon be the home of the National Bio and Agro Defense Facility. It is a $1.25 billion research facility nearing completion. Its mission is to of the facility is to protect U.S. livestock from foreign animal diseases, including zoonotic diseases that can pose significant threats to human health. NBAF will be the first biocontainment facility in the U.S. where there's a BSL-4 laboratory, which zoonotic pathogens for which there are no treatments currently exist. NBAF is operated by the U.S. Department of Agriculture with cooperation from the Department of Homeland Security. It's truly going to be a state-of-the-art facility. COVID-19, which possibly is a zoonotic disease, has only highlighted the importance for the U.S. to invest in this type of research. Are you engaged with USDA or Homeland Security on future research that could be conducted at NBAF in regard to zoonotic diseases? What kind of research at NBAF would be able to provide you with benefits in your mission of protecting a human life?
Let me just say that what we call One Health, the idea of human and animal health and the environment, has been a critical issue for preparedness and response. We've seen so many terrible diseases emerge from animals, and we haven't been sufficiently ready for them. Whether we're dealing with the genetic sequencing of the strains and whether the animal strains have adapted better to humans, or research into containment interventions, it's really important. And so a principle of collaboration between Health and Human Services and the Department of Agriculture and Department of Homeland Security is very important. I can say that the CDC and USDA both have oversight over select agents that are evaluated in those BSL-4 facilities, and we work very closely with them to make sure that there's animal health is protected and that human health is protected, and that the laboratories that are studying these pathogens do so safely without risk to the surrounding community. As to exactly where we are with collaboration, I think we'll have to get back to you, but it's congratulations on the facility, and I think we'll look forward to working
This is
together.
a post-9/11 development and designed to replace Plum Island and the research done there in a new advanced laboratory. I would welcome the opportunity to connect you and the folks at either agriculture and those in Kansas as well. What, if anything, is the steps that CDC or perhaps broader the federal government should do to bring China into this world of helping us combat diseases, the spread of viruses? Is there any opportunity for us to get better information and any way that we can insist, encourage, or demand that China behave differently than what they did after the arrival of the evidence of this disease in China?
I think that we are all a global community at this point, and that when there's a threat anywhere, there's a threat everywhere. And so when it comes to our health, when it comes to science, it is helpful to have these connections. We have an office, a regional office in China where we exchange scientific information. So I think around the global community, it's important that we convey scientific information.
What's your evaluation of what cooperation occurred between China and the United States in regard to COVID-19, and has anything changed to increase or decrease that cooperation now?
The WHO has done a study, has numerous interactions to evaluate this. My understanding is that there's another phase of that study underway, and I think that that's really critically important because, quite honestly, and in my review of that study, and many have spent many hours reviewing the studies, there was not a lot of transparency in line-level data that is that we're able to use to interpret.
Dr. Walensky, there's probably a longer answer than that, and maybe we can have that when you and I have a chance to have a conversation. A couple of things in the 30 seconds I have left. I would highlight, you and I have had this conversation, Dr. Frieden encouraged me in regard to the Global Health Security Program, and I've tried to be an advocate for that program in this appropriations subcommittee with some success. And I just would, I'm interested now, you don't have to answer this question in the lack of time that I have for you to do so, but I would love an answer that tells me how I should prioritize. You've said it, what happens elsewhere matters to us, and absolutely the truth, and we've known that for a long time. But how do we prioritize now with the consequences of this pandemic in the United States? How do we prioritize the appropriations that will go to programs that are outside the United States that are protecting us as well as citizens of the world as compared to things that need to be done domestically, which are significant? So I'd love to have a broader discussion about where those priorities should lie. And finally, I would indicate I'm reading a book, which I do regularly, the Premonition, and I don't know whether you've read it, but I'm 2/3 the way through. It's not terribly derogatory, but not terribly complimentary of the CDC, and I'd welcome any suggestions that you have of what the takeaway should be for CDC, or if it's a book that is worthy of learning something from.
Thank you, Senator. I'd be happy to engage in those conversations. I have not yet read The Premonition, although I know of it and I know many people who are in it. And what I will say is there are many lessons that we can learn, some things that we have to do better at the CDC, and some things that we have to do better as a country in investing in multi-year public health infrastructure. I think among the comments in them I'm familiar with was one of the issues that I heard firsthand, lab receiving results by fax and, people working in data entry to do that. That is not a public health infrastructure of the future. It's not a way to respond to a pandemic. And so I think the lessons to be learned from the book are, yes, we have to understand where things could have gone better at CDC, and we need multi-year infrastructure resources to make sure that we have, workforce and data and labs up to snuff to tackle whatever they need to tackle in the future.
It seems well written to me and by a credible author, and I would encourage you to learn from it as I'm trying to. Madam Chairman, the last comment I'd make is one of the things my takeaway is the failure for CDC to authorize testing early on in circumstances in which it appears to me testing should have been occurring.
Thank you. Senator Shaheen.
Thank you, Madam Chairman, and thank you, Dr. Walensky and Dr. Shukat, for your service to the country and for being here this morning. Dr. Walensky, I very much appreciated our conversation earlier this week, and one of the things we talked about is the continuing challenge of the opioid epidemic that we're facing in this country. New Hampshire, like West Virginia, has been very hard hit. We are one of the 10 states in the country that's been hardest hit by the epidemic, and I was pleased that Congress provided some new flexibility to deal with the epidemic last year by including meth and cocaine as part of the drugs that could be included in programs to address the opioid epidemic. But can you talk, one of the things we discussed was the challenge that I've heard from providers in New Hampshire, that we don't have a response for those overdosing on meth in the same way that we have Narcan for those who have overdosed on opioids. Can you talk about what the CDC is doing to approach this issue and what kind of help you might have available for states like New Hampshire?
Thank you, Senator. I'm thinking back to sort of 6 months ago and what we needed to do when we knew that one of our patients had relapsed and how we get them into care. And it was our community health workers that knew where to find them. They knew where they were getting their drugs, and they knew where to find them and to say somebody cares for you and brought them back. And that, I think, is what we need in our public health infrastructure. We need the community workers who live in the community, who are from the community, to make those interventions to find the people. And that's really among the things that I think this public health infrastructure is going to be able to do. Certainly, we don't have something like naloxone for meth overdose, and that is unfortunate right now, and we need to address that. And then, quite honestly, we have statistics of the overdoses and the lethal overdoses. They're terrible, and yet we also have statistics of all these hospitalizations that are happening among young people that I was taking care of just 6 months ago. 30-year-olds getting their second valve replacement. So this is something that we have to tackle. And it's not just that we have to tackle it with Narcan in a given community. We have to tackle it community by community because they're all different kinds of communities, and we need the workers to be able to do so.
Well, thank you. I know this is not a CDC issue, but I hope that you will weigh in if you have the opportunity with the administration on the importance of the set-aside funding for states like New Hampshire that have been hardest hit, because that's allowed us to set up a real statewide response to the epidemic. I want to go on to PFAS, which is an emerging contaminant until we get the EPA to designate it as something else, but it's one that we've seen very directly in New Hampshire, and especially appreciate the response from the Agency for Toxic Substances and Disease Registry, which has been so helpful in undertaking a comprehensive health study. And in New Hampshire, Portsmouth and Pease, former Air Force Base, have been one of the sites designated. But one of the things we learned is that too many of our members of the medical community don't have any idea about PFAS. They don't know what it is. They don't know how to respond to it. They don't know whether testing is appropriate or not. And I worked with Chairman Murray and Ranking Member Blunt last year to fund a grant program to help educate our physicians. And I'm very interested in how that unfolds and the work that the CDC might be doing to help and ATSDR to educate our medical community. So I don't know if either of you can speak to that on the update on where that effort stands.
This has been such a complex and challenging area, and I really appreciate the leadership that you've shown and the
Thank you.
support you've given, and also the advocacy for us to learn what we need to learn so that people who've been exposed and the clinicians that they see know what to do. To get a result and then not know what it means and what you're supposed to do about it is challenging. So we really are incredibly grateful for the resources that are letting us begin to pave the way to get those answers. I don't have specifics on the results of studies yet, but I know it's a very high priority for ATSDR and the leadership here.
And do you have, at one point in the last year, there was a suggestion that there was a connection between exposure to PFAS and severity of COVID-19. Do we have any more information about that?
You know, I know that question came up and that we were looking into it. I don't believe we have a final, but we can get back to you if we do.
That'd be great, thank you. If you could just let me know either way what we know about that, I'd appreciate it. Thank you, Madam Chair.
Senator Capito.
Thank you, Madam Chair, and thank you for our witnesses today, both of Dr. Walensky and Dr. Shuchat, and I wish you the best in your, we won't call it retirement, in your repurposing, how about that, wherever you may land. Let me ask specifically, Senator Shaheen and Senator Manchin mentioned, obviously, the overdose rates in the state of West Virginia, so I won't go back through that, but I am concerned. Dr. Walensky, I know you have a focus on ending the HIV epidemic. I know this is in your academic career as well. You mentioned it in the President's budget. West Virginia received a grant in the Integrated Viral Health, or Hepatitis, surveillance, targeted funds to help us address certain areas, hotspots, I guess you would call them. But we are not an ending HIV epidemic focused jurisdiction, nor any of our counties. And in your testimony, you state that increased funding in the budget is for 4 key strategies in the focus areas, but not to increase the amount of focus areas. So my question is, I think we need to be a focus area because we have some of the highest incidents. And how do you expand that footprint, or how can you help me with that?
Thank you, Senator. As I think you noted, my 20-year career prior to January 20th was in doing exactly that, and I was really encouraged by ending the mission to end the HIV epidemic really through diagnosis, prevention, treatment, and response. You know, when the initial tranche of HIV and the HIV epidemic money went out, it was to areas with the highest numbers, with truly a multi-year plan to expand to other areas that we needed to really curb things in the areas with the highest numbers, take some of the lessons that we learned and expand to some of the other areas. And so I have a vision and hope that we'll be able to do that in the years ahead and to continue that expansion.
Thank you. So expansion into areas such as ours, I think that would be welcome. I would make note that in the initial disbursement of the vaccine, our state of West Virginia did an incredible job working with our public health infrastructure. But I think one of the lessons that we learned, and that I hope this becomes part of a manual to address future issues, is public health infrastructure can't do this by themselves. Not to what we saw at the breadth of what we saw. So what happened? We had volunteers, we had county city governments, we had our National Guard. And so I would encourage you, while I think increasing our public health infrastructure is absolutely essential, I think growing those partnerships could be even more essential because there's a roadmap there to success. And so I just put that on your radar screen as you're looking to expand. One thing I'd like to ask, and Senator Blunt and I were in the Oval Office when the announcement was made with the President that we were going to lift the mask mandate, and I cannot tell you how joyful we all were as we ripped our masks off and had a great meeting after that. But there's confusion still, and you know, if we're going to get more people vaccinated, which is the ultimate goal, all the way down through the age levels, we can't have this confusion because it just. Should I get my child vaccinated? You know, how old can my child be to get vaccinated? Does my child need to wear a mask at school? Who's the ultimate decider here? Is that the CDC? Is it the president? Is the governor? Is it the NIH? I mean, there's just too much coming at young families in particular, I think, to be able to feel, number one, that their child is safe and they're doing the right thing for them to go to school, but also to get rid of that, I would say not anti-vaxxer, but vaccine hesitation. I think that's a large part of the people that are left as yet to be vaccinated. So how would you respond to that question?
Thank you. The guidance that we put out on Thursday was individual guidance for people who are fully vaccinated can take off their masks.
Right.
I was pleased actually the day before that the FDA had authorized and the CDC had recommended vaccination with Pfizer vaccine for individuals as young as 12 years old. That is now recommended. And my 16-year-old has been vaccinated, and we have a lot of community workers out there encouraging vaccination of youth. And in fact, over 600,000 people between the ages of 12 and 15 have been vaccinated just in this last week. In terms of guidance, the CDC provides science-based, evidence-based guidance to anybody who is the consumer of said guidance, whether it be industries, jurisdictions. Importantly, the country is not uniform. And so I think you really do need to interpret our guidance in the context of what is happening in your community. And that's really important in the context of a transmissible agent. Why is that important? Because the virus is going to be an opportunist. If you have a county that has low vaccination rates and high rates of disease, that county may interpret our guidance differently than a county that has high vaccination rates and low incidence of disease. So we really do have to do this at the local level because, in fact, the virus will, where there's less vaccination, the virus will emerge.
So what do you say to the under 12 population, elementary school, the parents of those children who have low vaccination rates, is probably close to nothing. They have low incident of infection, and all the studies that show the younger generation is not as affected as older and even more senior. What do you tell them? Listen to your governor, listen to your school board?
So what we would say is vaccines are coming for youth. We are hopeful to they're doing dose de-escalation studies now down to 9 years old, soon thereafter down to 6, soon thereafter down to 3, and then down to 6 months. So we are working towards getting a vaccine that will be available for all people.
So when would that?
Some of it depends on how much disease is out there in the community, so we can't exactly predict. But we're hoping to have more available in late fall and by the end of the year through these dose de-escalation studies. And then, of course, I think the guidance that we have had for schools has actually demonstrated that even in the absence of vaccinations, schools can be a very safe place, given the guidance that we have. We've recommended that schools not change anything for this school year because it will be hard for our youth to get fully vaccinated before the end of this school year. We'll be updating that soon, and then given that guidance, there'll be policies at the local and jurisdictional levels.
Well, I still think, I know you probably would agree that it is a bit confusing to folks all around the country who have children in school. I would just be as clear and concise and definitive when this science comes forward and more vaccinations come forward, because I think it really is, it's really difficult, I think, for parents to decide how to do the right thing. Thank you.
Thank you. That ends our first round of questions, and I will start a second round for any senators who wish to ask additional questions. And Dr. Walensky, I will begin with you. The pandemic's deadly impact on communities of color show we do have a long way to go to address systemic racism and health inequities. Black and Latino populations are receiving vaccinations at disproportionately low rates, even as some of our recent polls suggest both groups are more likely than white people to say they want to get vaccinated. And according to the CDC website, data on race and ethnicity is available for just over half of vaccinated people. How is CDC working to improve vaccination access and collect more data on these demographic issues that we need to see in front of us?
Thank you very much for that question, because we are working hard. We have placed our community vaccination centers, our mass vaccination centers, in areas that have high social vulnerability index. They're doing an extraordinarily good job in getting our minority communities. Our federal retail pharmacy programs were were selected initially in collaboration with the state to see how we could get vaccine to the most vulnerable communities, to Black and brown communities. And just this last 2 weeks, federal retail pharmacy programs, 47% of the vaccines that they delivered were to minority communities. And then our federally qualified healthcare centers, in collaboration with HRSA, we've been delivering to people who are migrant workers, to people in rural communities, and people who have less access. One of the things that we've been able to do to improve our racial ethnicity data, and this has been challenging because some people are electing not to report it, is to use HIPAA-compliant electronic case reporting so that we can use cases, or this is on the case level, not the vaccine level, but looking at cases and then match it to medical records via CERN or via EPIC to be able to get case level data. We're working really hard with the counties to get both racial and ethnic minority data at the case and disease level, but then also at the vaccination level. And this is, again, one of those areas where our data has, our data infrastructure has not been robust enough to deliver this to us in real time.
Are you seeing any political ideology play into this decision to get vaccinated?
This is a personal choice. I think once we start saying this group wants vaccine, this group doesn't, then we start telling the wrong message. When I was taking care of patients with HIV, and I was told a new patient I had to deliver a new diagnosis, they always said to me, you deliver the diagnosis and then you pause and you see what that means to them. Right? Could it mean that they are worried about their baby, they're going to lose their job, they think they're going to die, they can't afford their meds? I think vaccine hesitancy is exactly this. What is it about the vaccine that is making you hesitant? Is it that you're scared you have to take the day off of work to get it? Is it that you saw a friend get it and they had a reaction? Is it that, wow, how did the science come so fast? And so this is not about politics. This is about understanding where individuals are, meeting them where they are, and understanding what it is that making them hesitant.
Okay, thank you. Dr. Schuchat, recent research on the impact COVID-19 infection has on pregnant women is really alarming. One study last month showed pregnant women with COVID-19 are 22 times more likely to die compared to women who are not pregnant who track the virus. What is the latest vaccine guidance for pregnant women?
Yeah, thanks so much for that issue. COVID complicates pregnancy, so women who are pregnant and get COVID have worse experiences with the infection than do non-pregnant women. More time in the intensive care unit, more risk of severe outcomes, including those rare deaths. COVID also complicates pregnancy by increasing the risk of prematurity and leading to other types of complications. While, as you know, clinical trials rarely enroll pregnant women, we are fortunate that there's been intense effort to get data about women who do get vaccinated while pregnant to understand what happens so that other women can learn from that. Based on what we know right now, we recommend that women be offered vaccines during pregnancy, that they're eligible to get them, and that they make a choice about it. That choice might be based on how they value that risk or that unknown, but we do have reassuring data right now about vaccines given, particularly in the third trimester, that have been followed and reported. We're continuing to follow and working closely with FDA on that. And so we'll be expecting this summer to have even more data, particularly about vaccines given earlier in pregnancy.
Okay. Is there any research about pregnant or lactating women who are vaccinated, transferring antibodies to their infants?
We have emerging data that antibody is transferred, and so we hope it will be like the influenza story, where getting vaccinated during pregnancy against influenza is really important because newborns and young children are very high risk for influenza complications. So good news so far, and continuing to follow that.
Thank you. Senator Blunt?
Thank you, Chair. The issue of a booster vaccine obviously is out there. So far, most of the people that have said they think we're going to need it are from the companies that are making the vaccine. Dr. Fauci, former CDC Director Tom Frieden, others have said there's growing evidence that there's may very well be enduring protection with the vaccine we have. Now, I've been a big supporter of the warp speed effort to invest early in vaccines that weren't approved yet, which I think made a big difference in availability. I do question the BARDA decision to purchase 400 million doses of Moderna and Pfizer as a booster dose. Were you asked about whether that was the right decision to make or not? And if you weren't, should CDC be involved in a $7.9 billion decision about a booster before we know whether we need one or not?
Thank you, Senator. I think the first thing to recognize, and this has been miscommunicated, so I think it's very important in the media, is that if you have received 2 doses of your Pfizer or Moderna vaccine, you are right now protected.
Right.
What we are looking at is whether we will need boosters over time. And I think that this is really, given how hard we were hit by this pandemic, I think it's really important to understand where we will be with that. Data suggest from SARS, not SARS-CoV-2, but from SARS, a similar coronavirus, that people have waning immunity over time. And if you looked at what happened in the SARS outbreak several years ago, you saw that people were eligible for reinfection. So there is biologic plausibility that there would be waning immunity after you were infected, and we just don't know when that will be. One of the concerns has been that if we first vaccinated our very most vulnerable, our people in nursing homes, that they may not have had as robust a response, and that they might be the first who, they would be a first who need a booster anyway because they were vaccinated first. But in fact, that they may not have had a robust response.
If we spend $7.9 billion, which I guess we did decide to do on May the 2nd, do we think those vaccines last for some time?
I am not under the impression those are being made right now. I think part of the issue is, what do they need to look like? Are we going to boost with the exact same mRNA structure as we do now, or might we want to boost with a variant structure? And I think those are all conversations that are happening.
Well, I think that's a pretty big spending decision to make based on the information we have, but we can talk about that more later. If we do go forward with booster vaccines, are you all working to see if in an adult immunization program we'd try to combine more things with that booster, a flu shot, a whatever other shot an adult might need at this point?
I think it's pretty clear that we've had an immunization program for adults that wasn't prepared for what we needed in this in this structure. And yes, I think it would be advantageous. Currently, we don't have data as to whether you can co-administer vaccines. Those data we're looking for, and in fact, the ACIP just opined on this last week because we're so behind on childhood immunizations, 11 million behind on childhood immunizations. So those are all the data that we're looking for, because I think it would be really great to be able to leverage what we're doing for COVID for influenza as well, or vice versa.
Exactly, and I hope you'll keep us posted on that as that happens. On data, that was actually where I was going next. The data, we obviously had a data shortage, of some confusion about what data to input, which was not as helpful as it might have been. Now, the committee, in what was then a fairly controversial decision even among our colleagues, we decided before COVID to invest $50 million in base funding over the last 2 years for data. When COVID occurred, and the numbers we were suddenly looking at and dealing with, we did another $500 million. Dr. Sukkot, tell me where you think we are on better data preparation in the future, or being better ready in the future to have data and the tracking that comes with data. Where are we, and where would you think that heads CDC in the next fiscal year, for instance?
This is essential. The 50 million base appropriations were vital, but you saw how behind we were. This is critical. We are so far behind, even with the increased resources. This is a long-term need. We're better, but we're not where we need to be. We've made huge progress this past year with electronic lab reporting of enormous numbers in terms of how many people were being tested and getting us daily data. But the data were not necessarily complete, and as you heard, the race ethnicity data often missing. We have a need to move to the cloud of many of our systems. We have a need to become, have a workforce that can handle the data at the local level, at the state level, that can use these sophisticated tools and not just react, but predict. So we still have a long way to go, but COVID, we've made a lot of progress on. We need to make that progress across the spectrum of the public health issues.
Well, data and tracking and other things, I think, are an important part of the future of health, and we want to be helpful. And I would hope that the $550 million collectively in the last couple of years has made a substantial difference in where we're headed. Thank you, Chair.
Senator Moran? Thank you. Senator, I have one additional question for you. The CDC faced unexpected difficulties, as we all remember, during those opening phases of the pandemic, especially around testing. And delays in establishing a large-scale testing likely allowed the virus to spread undetected, as we know. One of the several factors that really hampered our efforts to contain that outbreak. Dr. Walensky, I just wanted to ask you today, what lessons has CDC learned from the experience in those first few weeks?
There's been a lot of research going into what we could have done better during that period of time. My responsibility is to own that and to make sure that we are better. Among the challenges were quality assurance, quality control programs that were not in place the way they should have been. And in fact, among the things that we're doing is to ensure that all labs, research and diagnostic labs, are fully accredited. So we are learning those lessons. Those were hard lessons to learn. I do also think that we need to recognize that among CDC's responsibilities is that when we have a new infectious pathogen, we are responsible for creating the diagnostics for that pathogen. Once we have done so, we need interagency collaboration with ASPR, with FDA, to with the private sector to ensure that we can bring it to scale. We're now at this morning we did 1 million tests a day. Yesterday we're testing 1 to 2 million a day. That scale up has to be interagency. And so yes, we have a lot of lessons that we can learn from what occurred, and we are learning them and taking resources that have been provided to us so that we can not just take a line item and improve X lab, but we can improve all of the labs and through this accreditation process, for example, but then also to be able to scale at a national level.
Okay, thank you. Thank you very much. That will end our hearing today, but I do want to thank both Director Walensky and Principal Deputy Director Schuckert for joining us. Thank you to all of our colleagues on the committee who participated as well. For any senators who wish to ask additional questions for the record will be due 1 week after the President's budget is delivered at 5 p.m. The hearing record will also remain open until then for members who wish to submit additional material for the record. The committee will next meet in Dirksen 562, Wednesday, May 26th at 10 a.m. for a hearing on the Biden administration's budget request